We're going to be talking about iron deficiency anemia. So before we get into it, let's just define what anemia is. Anemia is defined as where there's deficiency of red blood cells or of hemoglobin, resulting in pallor and weariness, which is also known as weakness. Now, the classification of anemia, according to clinical labs, i.e. when someone does a blood test, can be due to three main factors. The person usually checks for hemoglobin concentration, hematocrit, as well as mean size corpus volume, and hemoglobin concentration, known as MCV and MCHC. Now, hematocrit, just to define it again, is the ratio of volume of erythrocytes to that of the whole blood. The normal ranges lie for males between 0.41 to 0.51, and for females slightly lower at 0.36 to 0.45. You need to keep these critical values and normal ranges in your head. Hemoglobin levels, usually for adult males, is between 126 and 174. Usually I remember it as 130 to 175 being the upper limit, and for women it's slightly lower at 117 to 161. So, in this picture in front of you right now, the main things that would look for when someone comes in with anemia is you would test for the hemoglobin, you would test for hematocrit, you would test for the mean cell hemoglobin, mean cell volume. Up on screen I've highlighted all the ones that's important that you look for. Now, typical blood results. So here on screen now you have a typical blood test result. So you can see that this patient has hemoglobin HB level of 144 when the reference value, so it lies within the reference value, so therefore it seems to be normal. Next we check for the red blood cell count, 4.67, again normal. Hematocrit 0.429, lies within the range again. MCV lies within the range. MCHC and MCH all lies within the range, so this person seems completely normal. So does this person have anemia? You can't say they don't have anemia, because in terms of anemia there can be normocytic, normochromic anemia. But now if you look at the serum ferritin, that is also normal ranges. So this person does not have any sort of anemia. It's a completely normal blood result. Again, we have a second results. Again, we look for hemoglobin 129, which is normal. Seems like a female patient because the reference range is between 115 to 165. Hematocrit is 0.42. MCV, MCHC, and MCHC all seems to lie in normal. Hence, the person does not present with any sort of anemia. Look for serum folate, i.e. serum iron, is again in the normal range. So again, a normal patient. Now, what do you expect to see on a typical blood result for an anemic patient? So on screen now we have hematology. So hematology is a certain type of blood test where it looks at every single blood cell within your blood. Now you can see hemoglobin is 108 and the reference value is 120 to 160, so it's slightly lower. Hematocrit again is low, MCV is low. So MCV, MCHC and MCHC, i.e. the size, volume and concentration, or known as the Vintro calculation values, these are all low. This ticks one criteria. Hemoglobin is low and hematocrit is low, so therefore this ticks three parameters, as I said previously. So therefore this person is definite have anemia. Now, we can classify this anemia because they have a low MCV, low MCHC and low MCHC. This person usually is diagnosed with microcytic hypochromic. So they have a small size. The red blood cells is usually very small and very not so dense dark red. Instead it will be very pale. So you can see on screen what the doctors have diagnosed. WBC morphology, i.e. white blood cell count, it seems to be normal. The pathologist has come to a conclusion that this person has some sort of microcytic hypochromic anemia, as we expected. So we know, but on the biochemistry review, they've tested both ferritin. Ferritin seems to come out normal, but on vitamin B12, remember vitamin B12 deficiency was involved with not microcytic, but macrocytic. So I've labeled it on the screen. Macrocytic anemia was when the MCV was above 95 femtoliters, whereas microcytic was when it was below 80 femtoliters. Now, macrocytic was considered as two different parts, megaloblastic and non-megaloblastic. Megaloblastic was vitamin B12 or folate deficiency. So this does not relate to this part of the video, but I just put it in there so that you don't get confused. Since they look for vitamin B12, think macrocytic in your head as well. But in this case, this person has microcytic hypochromic anemia. Now, iron deficiency anemia occurs usually when iron loss exceeds what the iron intake in the body is. Usually, the amount of iron stored in someone's body is usually 1,000 milligrams, which can last around 3 to 4 years. So if you're not someone who consumes iron on a daily basis, your body still can produce iron by itself for the rest of 3 to 4 years. Iron is important in hemoglobin production, as well as iron is the hemoglobin. Within that hemoglobin, there's four iron molecules, and each iron molecule can carry up to one oxygen molecule. So therefore, altogether, one hemoglobin carries 4 oxygen molecules. When you have low iron content, therefore there's not a functioning hemoglobin, so therefore you would end up having anemia because of hypoxia. Anemia would then present with fatigue, irregular heartbeats, chest pain, weakness, shortness of breath. These are the common types of symptoms. Now, facts about iron deficiency anemia, or etiology if you want to name it. It's the most common cause of anemia on the planet. Usually children are more affected between the ages of 6 to 24 months, And this is suspectively because they don't get enough iron through breast milk, or maybe they're not being malnutrition, or the nutrition of iron in their food is not high enough. And iron deficiency in baby once is mainly commonly seen between 6 to 24 months. 3% of toddlers aged between 1 to 2 years, and 2% to 5% of adolescents, girls and women, are of childbearing age usually present with iron deficiency. So iron deficiency can come when there's an increased need of iron. For example, in pregnancy, you have to provide iron for yourself and for the baby as well. So therefore, you need to increase the amount of iron you intake. Hence why doctors usually check for folate levels, or or they usually put pregnant women on increased iron tablets. Now, iron deficiency in adults is usually due to various causes. Someone who has undergone gastrectomy, so after total gastrectomy, which is removal of the stomach, or even subtotal gastrectomy, you're not able to absorb the amount of iron from dietary conditions, so therefore you would have a decreased amount of iron absorption. Someone who has celiac disease is on screen now. You can see the normal microvilli in the small intestine is not functional, therefore you cannot absorb the nutrients. Or inflammatory bowel disease. And someone who presents with GERD or gastroesophageal reflux disease is again not able to take in enough iron because of prolonged treatment with H2 blockers as well as acid pump blockers, which cause defective iron absorption. Also, people presented with Spur syndrome, which is some sort of malabsorption syndrome where you're not able to absorb iron properly. But the main one to remember is in adults mainly, iron deficiency usually comes because, like we said previously, is when your amount of intake of iron is less compared to the amount of loss. And this is usually males are due to chronic blood loss due to some sort of hemorrhage or cerebral vascular disease, DICs, like disseminated intravascular coagulopathy, etc. Benign and malignant tumors can also contribute to iron deficiency, and postmenopausal women are also affected. People infected with H. pylori as well as hookworms are also iron deficient because of the inability to absorb iron. Now, what do you see under a microscope of an iron deficiency anemia? So usually when a clinician detects or suspects on someone with iron deficiency anemia, i.e. they have a microcytic hypochromic type of anemia, according to the blood test results, usually send it off to a blood smear or to analyze under a microscope. You're able to see in early phase, if the patient has come in very too early, you'll not see a big difference. It'll be normochromic and normochromic. But in later phases, so later on, once the anemia is properly kicked in, you would end up seeing microcytic, hypochromic, and anisocytosis. Remember, anisocytosis was variation in the size, and polycytosis was in the shape. So on screen now, you can see a blood smear which has been done. So here, where the mouse is pointing to, you can clearly see polycytosis because of the different type of shape. You can see macrocytic because the red blood cells are quite small, and you will see hypochromic because they're not very dark. Anisocytosis because you can see various different variations in the width of the red blood cell. On the left, you see a more normochromic. So this is how a normal person's blood smear or a normal red blood cell is meant to look like, where it's very uniform, almost similar shape, very elliptical and spherical in size. There is no polycytosis or anisocytosis present. Again, one more on screen is iron deficient anemia blood smear, so you can see polycytosis straight away, where it's different types of shape. You can see various different small red blood cells leading to microcytic, and they're not very dark and red like this one, so they're hypochromic. So remember, microcytic hypochromic anemia is usually iron deficient. Now, what blood test results do you look for someone who has iron deficiency? So the hematology, i.e. what looks for the main blood cells, and there's biochemistry as well. Now, hematology, you would look for reticulocyte count, MCV, hemoglobin, hematocrit, leukocyte count, leukocyte meaning all of the white blood cells, and granulocytes. Usually, reticulocyte count is the first thing that you look for. So you remember reticulocyte count, if it was below 2.6 and it was microcytic or macrocytic, you can see iron deficiency falls under this category. If I'm speaking too fast, pause the video and familiarize yourself with what I'm speaking. Now, MCV, on the other hand, usually would be decreased in anemia anyway, regardless. So HB concentration, hemoglobin will be decreased, hematocrit will be decreased. Leukocyte count, generally speaking, leukocyte would not be affected that much, but sometimes it can be decreased. Granulocytes, i.e. neutrophils, basophils, and eosinophils, these are all usually normal, very normal to low. So you can see on the screen now. So reticulocyte counts will be decreased, MCV decreased, hematocrit decreased. Now, the main things, so once you have these results on the screen, your doctor or your clinician might advise you to go for a further biochemistry test where they check for other things to narrow the diagnosis down to iron deficiency. So they usually check for serum iron levels. In iron deficient anemia, your serum iron levels usually are low. Then they also check for TIBC, which is known as the total iron binding capacity. This is the ability of your blood to bind to iron. Usually with someone with iron deficient anemia, i.e. because there isn't enough iron, the moment you give iron into their body, the binding capacity is usually very high. In iron deficient anemia, TIBC is increased, but in chronic anemia it's decreased. You also look for serum ferritin levels. Ferritin is the storage molecule where iron is stored inside the liver. Also, you look for transferrin receptors, which is increased. Transferrin is the molecule that usually binds to iron and transports it around through the blood. So, specific markers, once you've gone through the basic ones, which is mentioned before, the reticulocyte count, MCV, HP, then you look for serum iron, TIBC, total iron binding capacity, serum ferritin, and transferrin receptor sites. Serum iron will be decreased, binding capacity usually will be increased, serum ferritin will be decreased, and transferrin receptors are increased because there's less iron to bind transferrin, so the receptors are they're less occupied, so they're more readily available. Now the management, usually the reference values for serum iron and TIBC are on screen. Memorize this for your understanding. The management usually involves administration of ferrous iron 200 mg per day and monitoring of HP once you administer it after the 5th day and subsequently 3 weeks is important. Usually, upset stomach, nausea, diarrhea, and faintness, and vomiting, dark stools, and constipation is associated with iron supplements, and you should advise your patients at all time when taking iron tablets. Now, signs and symptoms of anemia are common anemia, iron deficient anemia, very similar: pallor, low blood pressure, palpitations, systolic murmurs, as well as fatigability, which is the main one, shortness of breath and dyspnea on exertion, faintness, vertigo, palpitation. But the ones specifically I wanted to know there are specific ones for iron deficient anemia is Koilonchyia, which is basically brittle nails, hair loss, Plummer vision syndrome. So someone with iron deficient anemia usually presents with glossitis, inflammation of the tongue, as well as esophageal webs, i.e. some almost like varicose veins. So thank you for